Hello everybody, I'm Dr. Armen, Professor Armen Astvatsatryan from Yerevan, Armenia. For you, I'm Dr. Y, yes, and today we'll talk about hemoptysis. Hemoptysis, what is hemoptysis? Is a coughing up of blood from the respiratory tract. And massive hemoptysis is a production of more than 600 milliliter of blood, about a full kidney basin's worth, within 24 hours. About pathophysiology of hemoptysis. Most of the lungs blood, 95%, circulates through low pressure pulmonary arteries and ends up in the pulmonary capillary bed where gas is exchanged. About 5% of the blood supply circulates through high pressure bronchial arteries, which originate at the aorta and supply major airways and supporting structures. In hemoptysis, the blood generally arises from this bronchial circulation, except when pulmonary arteries are damaged by trauma, by erosion of granulomatous or calcified lymph node or tumor, or rarely by pulmonary arterial catheterization, where pulmonary capillaries are affected by inflammation. So, etiology of hemoptysis. Blood-streaked sputum is a common in many minor respiratory illnesses such as upper respiratory infection and viral bronchitis, for example. So the differential diagnosis is broad. In adults, 70 to 90% cases are caused by bronchitis, bronchiectasis, necrotizing pneumonia, tuberculosis. Primary lung cancer is an important cause in smokers more than 40 years old, but metastatic cancer rarely causes hemoptysis. Cavitary aspergillus infection is increasingly recognized as a cause, but it's not as common, of course, as cancer. In children, common causes are lower respiratory tract infection, foreign body aspiration. The most common cause of massive hemoptysis have changed over time and vary by geographic region, but include the following: bronchogenic carcinoma, bronchiectasis, tuberculosis, and other pneumonias. About causes of hemoptysis. For example, tracheobronchial source. Cause, so bronchitis, acute or chronic. Suggestive finding in acute bronchitis. Productive or non-productive cough. In chronic, cough on most days of the month or for 3 months per year for 2 successive years in patients with non-COPD, chronic obstructive pulmonary disease, or smoking history. Diagnostic approach in acute phase of bronchitis, of course, clinical evaluation. In chronic, it's a chest X-ray. Bronchiectasis, so chronic cough and muscles production in patients, and chronic cough and mucus production in patients with a history of recurrent infections. This is a suggestive finding. And diagnostic approach: high resolution chest computer tomography and bronchoscopy. Broncholitis, suggestive findings: calcified lymph nodes in patients with history or prior granulomatous disease. And diagnostic approach: chest computer tomography, bronchoscopy. Cause of foreign body, for example. Cause of hemoptysis. Foreign body, typically chronic and undiagnosed. Suggestive finding: chronic cough, typically in infant or young child, without symptoms of an upper respiratory infection, sometimes fever. Diagnostic approach, so just for foreign body: chest X-ray, sometimes bronchoscopy. Tumor, bronchogenic, bronchial, metastatic, Kaposi sarcoma. Night sweats, suggesting finding, weight loss, history of heavy smoking, risk factors for Kaposi sarcoma, for example, HIV infection. A diagnostic approach, chest X-ray, computed tomography, bronchoscopy. Pulmonary parenchymal source as a cause of hemoptysis. Acute granulomatous disease, tuberculosis, fungal, parasitic, syphilitic, or mycetoma, including aspergilloma, fungus bowl. Suggestive finding fever, cough, night sweats, and weight loss in patients with known exposures. Often history of immunosuppression. Diagnostic approach, chest X-ray, chest computed tomography, microbiologic testing of sputum samples, or bronchoscopy washing. Good posture syndrome, suggestive finding fatigue, weight loss, often hematuria, sometimes edema. Edema, of course. And a diagnostic approach, urinalysis, creatinine levels, renal biopsy, antiglomerular basement membranes testing, and CANCA, CANCA testing. Granulomatosis with polyangiitis, suggestive finding often chronic, bloody nasal discharge and nasal ulcerations, often joint pain and skin manifestations, nodules, purpura, gingival thickening and mulberry gingivitis, saddle nose and nasal septum perforation, sometimes renal insufficiency is the suggesting findings. And diagnostic approach, biopsy of any affected area, for example, kidney, skin with CANCA testing, and demonstration of vasculites in small to medium-sized arteries. Bronchoscopy is a diagnostic approach. Lung abscess, cause of hemoptysis, suggestive findings, subacute fever, cough, night sweats, anorexia, weight loss, poor dentition. Diagnostic approach, chest X-rays showing regularly shaped cavity with air fluid levels. Lupus pneumonitis, suggestive finding fever, cough, dyspnea, and pleuritic chest pain with a history of systemic lupus erythematosus. So diagnostic approach, chest computer tomography showing alveolitis, sometimes bronchoscopy washing showing lymphocytosis or granulocytosis. Pneumonia, suggestive finding fever, productive cough, dyspnea, pleuritic chest pain, decreased breath sounds or agaphony, elevated WBC count. Diagnostic approach, chest X-ray, blood and sputum cultures in hospitalized patients. Primary vascular source, aortic aneurysm with leakage to the pulmonary parenchyma, suggesting finding back pain, aortic aneurysm. So we know aortic aneurysm. So diagnostic approach, chest X-ray showing widened mediastinum, chest computer tomography angiography as diagnostic approach. Another cause is arteriovenous malformation, suggesting finding presence of mucocutaneous telangiectasia, or peripheral cyanosis. And diagnostic approach, chest computer tomography or pulmonary angiography. Elevated pulmonary venous pressure, especially in mitral stenosis, left-sided heart failure, Suggestive findings: crackles, signs of central or peripheral volume overload. It's a suggestive finding. For example, elevated neck veins, peripheral edema, dyspnea while lying flat, so-called orthopnea, or appearing 1-2 hours after falling asleep, paroxysmal nocturnal dyspnea. And diagnostic approach: ECG, blood, BNP measurement, echocardiography, and echocardiography. Pulmonary artery rupture, suggestive finding: recent placement or manipulation of a pulmonary artery catheter. Diagnostic approach: emergency chest computer tomography angiography or emergency pulmonary angiography. Pulmonary embolism, another cause, So suggestive finding: abrupt onset of sharp chest pain, increased respiratory rate and heart rate, particularly in patients with known risk factors for pulmonary embolism. Computer tomography angiography or VQ scanning, Doppler or duplex studies of extremities showing findings of DVT. Tracheal innominate artery fistula, placement of suggestive finding: placement of tracheostomy tube within the previous 3 days to 6 weeks. And diagnostic approach: identifying hemorrhage from endotracheal tube in compatible clinical setting. So miscellaneous, some causes of hemoptysis: pulmonary endometriosis, catamenial hemoptysis, suggesting finding: recurrent hemoptysis during menstruation. It's a suggestive finding. And diagnostic approach: sometimes therapeutic trial of oral contraceptives. Systemic coagulopathy or use of anticoagulants or thrombolytics. Suggestive findings: patients receiving systemic anticoagulants for treatment of pulmonary embolism, DVT, or atrial fibrillation. Patients receiving thrombolytics for treatment of stroke or myocardial infarction. Diagnostic approach: PT, PTT, or anti-factor XA levels, cessation of hemoptysis with correction of coagulation deficit. Evaluation of hemoptysis, so history, of course. We start always with history. History of present illness should cover the duration and temporal patterns, for example, abrupt onset, clinical recurrence, provoking factors, for example, allergen exposure, cold, exertion, supine position, and approximate volume of hemoptysis, for example, streaking teaspoon cup. Patients may need specific prompting to differentiate between true hemoptysis, pseudohemoptysis, that is bleeding originating in the nasopharynx that is subsequently coughed up, and hematemesis. A sensation of postnasal drip or any bleeding from the nares without coughing is suggestive for pseudohemoptysis. Concomitant nausea and vomiting with black, brown, or coffee ground colored blood is characteristic of hematemesis. Frothy sputum, bright red blood, and if massive, a sensation of choking are characteristic of true hemoptysis. Review of systems should seek symptoms suggesting possible causes, including fever and sputum production, pneumonia, night sweats, weight loss and fatigue, cancer, tuberculosis, chest pain and dyspnea, pneumonia, pulmonary embolism, leg pain and leg swelling, pulmonary embolism, hematuria, good posture syndrome, and bloody nasal discharge, granulomatosis with polyangiitis. Patients should be asked about risk factors for causes. These risk factors include HIV infection, use of immunosuppressants, tuberculosis, tuberculosis, fungal infection, exposures to tuberculosis, long smoking history, cancer, and recent immobilization or surgery, known cancer, prior or family history of clotting, pregnancy, use of estrogen-containing drugs, and recent long-distance travel, pulmonary embolism. Past medical history should cover known conditions that cause hemoptysis, including chronic lung disease, for example, COPD, bronchiectasis, tuberculosis, cystic fibrosis, cancer, bleeding disorders, heart failure, thoracic aortic aneurysm, and pulmonary renal syndromes, for example, Goodpasture syndrome, granulomatosis with polyangiitis. Exposure to tuberculosis is important, particularly in patients with HIV infection or another immunocompromised state. A history of frequent nosebleeds, early bruising, easy bruising, or liver disease suggest possible coagulopathy. The drug profile should be reviewed for use of anticoagulants and antiplatelet drugs. Okay, physical examination. Vital signs are reviewed for fever, tachycardia, tachypnea, and low oxygen saturation. Constitutional signs, for example, cachexia, cachexia and level of patient distress, for example, accessory muscle use, pursed lip breathing, agitation, decreased level of consciousness should also be noted. A full lung examination is done, particularly including adequacy of air entry and exit, symmetry of breath sounds, and presence of crackles, rhonchi, stridor, and wheezing. Signs of consolidation, for example, agophony, dullness to percussion, should be sought. The cervical and supraclavicular areas should be inspected and palpated for lymphadenopathy, suggesting cancer or tuberculosis. Neck veins should be inspected for distension, and the legs and presacral area should be palpated for pitting edema, suggesting heart failure. Heart sounds should be auscultated with notation of any extra heart sounds or murmur that might support a diagnostic of heart failure and elevated pulmonary pressure. The abdominal examination should focus on signs of hepatic congestion or masses, which could suggest either cancer or hematemesis from potential esophageal varices. The skin and mucous membranes should be examined for ecchymatosis, petechia, telangiectasia, gingivitis, or evidence of bleeding from the oral or nasal mucosa. If the patient can reproduce hemoptysis during examinations, the color and amount of blood should be noted. So the red flags. The following findings are of particular concern: massive hemoptysis, back pain, presence of pulmonary artery catheter or tracheostomy, malaise, weight loss or fatigue, extensive smoking history, dyspnea at rest during examination, or absent or decreased breath sounds. So interpretation of findings. The history of and physical examination often suggest a diagnosis and guide further testing. Despite the many possibilities, some generalities can be made. A previously healthy person with a normal examination and no risk factors, for example, tuberculosis, pulmonary embolism, who presents with acute onset cough and fever, most likely has a hemoptysis due to an acute respiratory illness. Chronic disorders are much lower on the list of possibilities. However, if risk factors are present, Those specific disorders must be strongly suspected. Clinical prediction can help estimate the risk of pulmonary embolism. A normal oxygen saturation doesn't exclude pulmonary embolism. Patients whose hemoptysis is due to a lung disorder, for example, COPD, cystic fibrosis, bronchiectasis, or heart disease, for example, heart failure, typically have a clear history of those disorders. Hemoptysis is not an initial manifestation. Patients with known immunocompromise should be suspected of having tuberculosis or a fungal infection. Patients with symptoms or signs of chronic illness but no known disorders should be suspected of having cancer or tuberculosis. Although hemoptysis can be the initial manifestation of lung cancer in patient who is otherwise asymptomatic. Several specific findings are of note. Known renal failure or hematuria suggest pulmonary renal syndrome, for example, Goodpasture syndrome, granulomatosis with polyangiitis. Patients with granulomatosis with polyangiitis may have nasal mucosal lesions. Visible telangiectasis suggests arteriovenous malformations. Patients with hemoptysis due to bleeding disorder usually have cutaneous findings, petechia, purpura, or both, or a history of anticoagulant or antiplatelet drug use. Recurrent hemoptysis coinciding with menses strongly suggests pulmonary endometriosis. Menses, yeah. Testing. So, patients with massive hemoptysis require treatment and stabilization, usually in an intensive care unit, before testing. Patients with minor hemoptysis can undergo outpatient testing. Imaging is always done, typically chest X-ray, although sometimes, for example, with known bronchiectasis, computer tomography is initial test. Patients with normal results, a consistent history, and non-massive hemoptysis can undergo empiric treatment for bronchitis. Patients with abnormal results and patients without a supporting history should undergo computer tomography and bronchoscopy. Computer tomography may reveal pulmonary lesions that are not apparent on the chest X-ray and can help locate lesions in anticipation of bronchoscopy and biopsy. Computer tomography angiography, or less commonly ventilation perfusion scanning with or without pulmonary arteriography, can confirm the diagnosis of pulmonary embolism. Computer tomography and pulmonary angiography can also detect pulmonary arteriovenous fistulas. Fiber optic inspection of the larynx and airways must be indicated along with esophagogastric endoscopy when the etiology is obscure to distinguish hemoptysis from hematemesis and from nasopharyngeal or oropharyngeal bleeding. Laboratory testing is also done. Patients usually should have complete blood count, a platelet count, and measurement of PTT, prothrombin time, and PTT, partial thromboplastin time. Antifactor XA testing can be used to detect supratherapeutic anticoagulation in patients receiving low molecular weight heparin. Urinalysis should be done to look for signs of glomerulonephritis, hematuria, proteinuria, casts. Tuberculosis skin testing and sputum culture should be done as the initial test for active tuberculosis, but negative results do not preclude the need to induce sputum or do fibroscopic bronchoscopy to obtain samples for further acid-fast bacillus testing if an alternative diagnosis is not found. The cause of hemoptysis remains unknown in 30 to 40% of patients. but the prognosis for patients with cryptogenic hemoptysis is generally favorable, usually with a resolution of bleeding within 6 months of evaluation. Treatment of hemoptysis. Initial treatment of massive hemoptysis has two objectives: prevent aspiration of blood into the uninvolved lung, which can cause asphyxiation, of course, asphyxiation, prevent exsanguination due to ongoing bleeding. Exsanguination due to ongoing bleeding. Prevent this exsanguination due to ongoing bleeding. It can be difficult to protect the uninvolved lung because it's often initially unclear which side is bleeding. Once the bleeding site is identified, strategies include positioning the patient with the bleeding lung in a dependent position and selectively intubating the involved lung and or obstructing the bronchus going to the bleeding lung. Prevention of exsanguination involves reversal of any bleeding diathesis and direct efforts to stop the bleeding. Clotting differences can be reversed with fresh frozen plasma and factor-specific or platelet transfusions. Desmopressin is used to reverse platelet dysfunction associated with uremia and kidney disease. Tranexamic acid is an antifibrinolytic drug being increasingly used to promote hemostasis. Laser therapy, catheterization, or direct injection with epinephrine or vasopressin can be done bronchoscopically. Massive hemoptysis is one of the few indications for rigid, as opposite to flexible, bronchoscopy, which provides control of the airway, allows for a larger field of view than flexible bronchoscopy, allows better suctioning, and is more suited to therapeutic interventions such as laser therapy. Embolization via bronchial artery angiography is becoming the preferred method with which know to stop massive hemoptysis, which reported success rates of up to 90% of causes. Emergency surgery is indicated for massive hemoptysis not controlled by rigid bronchoscopy or embolization and is generally considered a last resort. Once a diagnosis is made, further treatment is directed as the cause. Treatment of minor hemoptysis is directed at the cause. Early resection may be indicated from bronchial adenoma or carcinoma, broncholitis, erosion of a calcified lymph node into adjacent bronchus, may require pulmonary resection if the stone cannot be removed via rigid bronchoscopy. Bleeding secondary to heart failure or mitral stenosis usually responds to specific therapy for heart failure. In rare cases, emergency mitral valvulotomy is necessary for life-threatening hemoptysis due to mitral stenosis. Bleeding from a pulmonary embolism is rarely massive and almost always stops spontaneously. If emboli recur and bleeding persists, anticoagulation may be contraindicated, and placement of an inferior vena cava filter is the treatment of choice. Because bleeding from bronchiectatic areas usually results from infection, treatment of the infection with appropriate antibiotics and postural drainage is essential. So antifibrinolytic drugs such as tranexamic acid are being increasingly used and studied in minor hemoptysis. Okay, key points. Hemoptysis needs to be distinguished from hematemesis and nasopharyngeal or oropharyngeal bleeding. Bronchitis, bronchiectasis, tuberculosis, and necrotizing pneumonia or lung abscess are the most common causes in adults. Lower respiratory tract infection and foreign body aspiration are the most common cause in children. Patients with massive hemoptysis require treatment and stabilization before testing. With massive hemoptysis, if the site of bleeding is known, patients should be positioned with the effect lung in the dependent position. Bronchial artery embolization is the preferred treatment for massive hemoptysis. Okay, my friends, that's all concerning hemoptysis. Thanks for your attention. Yeah, once again, please don't forget to make your donations, because without your donations actually can't exist. How to make this donation? You can find in description of this video in podcast or in YouTube. So in YouTube channel that you see, Dr. Y. It's me, Dr. Y. Or if you are in YouTube, you can use all YouTube possibilities. So find the, for example, make your donations directly as a sponsorship, or just directly to find the dollar sign of dollar, or up to you how to make. Or you can find my MasterCard of our channel in description of this video or of this podcast. So don't forget to make this, please. Actually, really, frankly, we can't exist without your donations. Absolutely. And don't forget to follow and subscribe, and to make ring on to be in touch with all news from our channel. So bye, and see you in another lectures. God bless you.